The next presenter is sort of someone who's especially near and dear to my heart because I'm his mentor. Lance Okeke is a clinical infectious diseases fellow. He got his undergraduate degree from Xavier University in Louisiana, and then went to Stanford University to medical school, and we were very lucky to capture him from Stanford, and Lance came out here to do his medical residency and stayed on to do his infectious diseases fellowship training. Lance and I have been working on issues of cardiovascular disease among persons who are HIV infected, and particularly we're interested in some of the clinical management issues that relate to persons with HIV who are living longer and are becoming more susceptible to cardiovascular disease as a consequence of that. Lance's topic in his presentation today is the management of cardiovascular disease risk factors based on HIV status, single center retrospective cohort study. Lance, welcome, and thanks for taking the time to do the presentation.
Thank you, Chuck, for the introduction. I want to thank Dr. Weinhold and the Duke CFAR for the opportunity to present this data. So I'm going to take the next 15 minutes or so to kind of look at what we've been doing over the last year, specifically looking at cardiovascular risk factors and the prevalence of risk factor management and how well we've done that amongst persons with HIV. So as everybody knows, over the last 20 years or so, with the availability of effective antiretrovirals, people infected with HIV have been living longer and longer than ever before. This data from the CDC illustrates exactly that the proportion of persons with HIV in the country that are over the age of 50. Back in 2001, that proportion was 17%. In 2007, that's climbed all the way up to 27.4%. And that number is expected to climb up to 50% or above by 2015. And so that's rapidly increasing. In light of that, we have to give further consideration to non-HIV related causes of chronic disease, chronic morbidity, and mortality in this population. Of course, the first chronic condition we consider when we consider non-HIV morbidity and mortality is cardiovascular disease. Among persons with HIV, cardiovascular disease is the third leading cause of non-HIV related death. And depending on what cohort you look at, between 11 and 25% of persons with HIV, 25% of deaths of persons with HIV occur in this population due to cardiovascular disease. We know from the DAD study that about persons with HIV have their first myocardial infarction on average 7 years earlier than non-infected persons. The DAD study, as most people in the room know, was a 33,000-person study looking at the effects of antiretrovirals on cardiovascular outcomes and metabolic profile issues in this population. The third point was highlighted in a study that was published earlier in the year in JAMA Internal Medicine in April of 2013. An 82,000 retrospective cohort study done by the VA Asian cohort out of Pittsburgh, Yale, and a number of other VAs around the country showed that after you adjust for traditional modifiable risk factors, persons with HIV are still 50% more likely to suffer a myocardial infarction than uninfected persons. And this was a pretty important study because it was the first study that definitively said that outside of traditional risk factors, by clinical data and by events, that persons with HIV do have an excess risk after you account for what the modifiable factors are. So we know that the pathogenesis of cardiovascular disease in persons with HIV is complex. I don't have time to go too much in detail about each component, but we know that chronic inflammation and immune activation are part of the issue, and that's a very active area of research currently. We know that the HIV virus is both directly toxic to endothelial cells, but also causes macrophage apoptosis and the atherogenesis based on the debris of macrophages within the vascular wall. Of course, the story of antiretrovirals and their role in cardiovascular disease and metabolic dysfunction is well documented. But I think the biggest issue, however, is what is the attributable risk of traditional modifiable risk factors and the excess risk that we do observe? That can we go by the premise that we've taken care of these HIV-infected persons over time, equivalent to people who are not infected. And so trying to flesh out exactly what the attributable risk of that factor is I think, issue of prime importance, because this is really the only part of this spectrum that we know what to do with. And so just to kind of put it in context, for the provider that's taking care of Magic Johnson at the age of 31 while he was still active in the NBA, what are the additional chronic disease challenges that his provider faces now that he's well into his 50s? He's 53 years old officially, but now he's well into his 50s and going beyond into his 60s. What are the active issues that they have to take into account? So a study in 2005 published in the Archives of Internal Medicine looked at what qualifies as an expert HIV provider. This was published by Landon and others and looked at 64 Ryan Care white-funded clinics around the country. Without going into too much detail, they looked at ID-boarded providers who specialize primarily in HIV and non-ID boarded providers, so general internists who considered themselves HIV experts and had more than 25 HIV-positive persons in their clinic panel. They compared those to non-expert generalists, and the kind of gestalt of the study was that, of course, persons with board experience in infectious diseases and HIV expert generalists took better care of their patients overall than non-expert generalists. So that seems quite obvious. However, if you look at this study, the factors that were looked at within the study were all HIV related. So issues like, were they on antiretrovirals? Did they receive appropriate PCP prophylaxis? Did they get their annual PPD testing? But the question that comes up is, if we looked at non-HIV related factors, markers of quality chronic disease care outside of what's related to HIV, what would the results of those studies show now? Given that about half the people around the country receive their care primarily from their HIV providers, are these providers accounting for all the non-HIV related issues that are coming up in this rapidly aging population? So in that context, the question we wanted to ask was, within our clinic population, as a first step, what is the prevalence of these modifiable CV risk factors? And the second question, and I think more importantly, is over time, how well have we done to manage these CV risk factors accordingly? And so we designed a retrospective cohort study, and we'll go over the numbers of patients we had soon, but we got our list from the deduced patient data portal and abstracted clinical data from the eBrowser electronic medical record. And our goal was to actually make a comparison, between infected patients and age, gender, and ethnicity matched uninfected controls. We looked into encounters prior to March 1st, 2010, and the major inclusion criteria was to really focus on the people at risk, so people over the age of 40 who are getting closer to the age of impending first event, persons that were followed over the course of 12 months or 3 consecutive visits, so to ensure that these aren't just people who are coming in and out of clinic, but they're actually sustained in care. And we actually apply that criteria, of course, for the unaffected controls as well. And then the major exclusion criteria include persons who had an alternate primary care provider, so people who were actually getting their primary care, their non-HIV related care from another provider, and thus had potentially 2 different providers taking care of them and a separate provider taking care of the HIV specifically. And of course, if they had a prior diagnosis of coronary disease, peripheral vascular disease, or stroke, then they were excluded from the study as well. I'm not going to go through this line by line due to time constraints, but this is the type of data we abstracted from the clinical record. And this is our consort diagram. So based on our deduced query of patients seen in our clinic, there were 5,250 patients followed over 12 months in our HIV clinic here at Duke. And when you apply the vital inclusion criteria, which was age over 40, in care for 12 months, that came down to 1,152. When you excluded people who had either an alternate provider or a prior diagnosis of MI, we were able to get a final cohort number of 890 HIV positive patients. Now, we attempted to match this one-to-one. However, we had 807 unaffected controls that specifically matched the persons by age, gender, and ethnicity in our infected cohort. So this is just basic demographic data on these patients. So the average age was about 49. And the male distribution was about the same because they were matched by gender. But I think just as importantly is just down here in this slide. So the question always is, what are the surrogate indicators these people have been in care for a substantial period of time? I think viral suppression, so persons that come to clinic regularly, are pretty reliably coming in and following the doctor's instructions and taking their antiretrovirals. And so the fact that within this cohort, almost 2/3 of the patients had durable viral suppression, so viral copies under 400 copies per cc for 12 months continuously was really important. The proximal CD4 mean was 542. So it was a pretty relatively healthy group of HIV-infected persons in this study, not just people at end stage. And so I think it was fairly representative of what we were trying to target. So looking at the issue of hypertension, it still worked out that both groups had about the same in terms of their blood pressure profile. So the mean systolic blood pressure and diastolic blood pressure were the same, essentially the same in the HIV-infected group and the uninfected groups. When you look at the overall population, however, you would expect that to be an equivalent proportion of persons if they have the same blood pressures in both groups. You expect that an equivalent proportion of persons would be on antihypertensives in both groups, but that wasn't actually the case. So in the HIV-infected group, about 36% of people were on antihypertensives amongst the entire population, as opposed to about half in the uninfected group. When you stratify that by persons with mean blood pressure over 140, the systolic blood pressure, the proportion of persons on antihypertensives amongst people with a mean blood pressure of 140 over the period of observation was about 2/3 in the HIV-infected group and about 87% in the uninfected group. So it's clearly a statistically significant difference there. Looking at hyperlipidemia, again, the profiles are surprisingly about the same. You would think with persons on protease inhibitors and the like that this number would be a little bit higher in the HIV-infected group, but it wasn't. It was essentially the same. And yet, in spite of that, there were significantly more persons in the uninfected group on antiretrovirals, so 24% in the uninfected group versus 15% on a statin, I should say, sorry. So there are more people on a statin in the uninfected group than in the infected group, and that reached statistical significance as well. We also did a sub-analysis on diabetics, and it's really interesting here because you can see the mean A1C in the infected group is about 6.9, and the uninfected group is about 8.3, and this probably reflects some degree of referral bias to diabetes specialists once their A1Cs were out of control. But it's widely accepted in the guidelines that all persons with diabetes should probably be on aspirin, yet in the infected group, about 1/5 of the patients that were diabetic and infected were on aspirin versus over half of the persons in the uninfected group. When you look at statins control, so the goal LDL for persons with diabetes should be less than 100. About less than 1/3 of persons in the infected group were on statins versus about 2/3 in the uninfected group. I think this is probably one of the more interesting slides and probably the last piece of data I'm going to show today. But again, just reincorporating, these people are around the age of 49 years old. We actually use JNC7 criteria now to define who actually did have hypertension. So not just mean systolic blood pressures over the period, but 2 consecutive visits with a blood pressure over 140. And about 17% of the HIV group had that finding, and 19% of the uninfected group. But still, again, you would think with the same proportions, the same amounts of people in both groups would be on antihypertensives, but that wasn't the case at all. In the uninfected group, about 3/4 of those patients that met the true criteria of hypertension were on antihypertensives versus about 60% of the persons in the infected group. And then looking at ATP3 criteria for persons on a statin, again, 18% of the persons in the infected group met those criteria, and we just pretty much used risk factor stratification based on their smoking history, their family history, and the like. And so you would expect that in this group, again, similar proportions would be on statins, but again, only about 1/4 of persons who met ATP criteria for lipidemia were actually on. And there's a caveat to this number is that this doesn't include persons who are on statins are well controlled in terms of their hyperlipidemia. These are people that just by absolute numbers were above goal and consistently above goal. And so looking at this number over here, there's about 25% of people that are consistently above goal by ATP criteria in the infected group versus about 40% of persons. And of course, there may have been different reasons why they weren't on statins, but the numbers are, the discrepancy is definitely there and it's real and meets statistical significance. So these are just some of the data that were coming out from our retrospective cohort study. One thing that's probably obvious to you that was missing was data on obesity and BMI and the like. And that's one of our next steps in our data abstraction to get more obesity data on these patients and see how that interacts with the lipid profiles that we're seeing and the overall outcomes. I think a very important next step, however, is how the persons with HIV that are receiving most of their primary care from a single provider compare to persons with HIV who exclusively get their HIV care from a provider but also get their chronic disease care from an alternate PCP. So the one provider versus two provider model. How do those patients do? And we actually have someone looking at that data right now to make that comparison to see if persons that have two providers do better than persons that get all their care exclusively from their HIV provider. Of course, the most interesting is looking at hard outcomes, so myocardial infarction, stroke diagnosis, and the like, to see if, since the groups are relatively similar, if there's an excess event rate in one group versus the other. That's going to take a little bit more time, and it gets a little bit more complicated, but I think that's the ultimate question that people want to hear and people want to know. I think also looking at surrogate markers of atherosclerosis in these persons, so FMDs and other carotid intimal thickness and the like, would be a very useful tool in this population. Since we have the clinical data on this cohort, we can look at the imaging studies, these populations, and look for evidence of premature atheromas in their carotids and the like. So I think it's a very exciting time for looking for the progression of atherosclerosis in what appears to be relatively similar groups. So in summary, HIV-infected persons, when they do meet criteria for hypertension and hyperlipidemia, seem to be on the guideline-recommended antihypertensives and statins less frequently than their uninfected controls, so age, gender, and ethnicity-matched uninfected patients. I think further investigations are warranted to see what the barriers of care to comprehensive cardiovascular risk management are essential in understanding exactly the attributable risk of modifiable risk factors and the excess risk we're observing in these big cohort studies in HIV persons with cardiovascular disease. I want to thank my mentor, Dr. Chuck Hicks, and most importantly, the Duke Center for AIDS Research for giving me this opportunity to present my data. Thank you.
Okay, I think we have a minute or two for questions. John.
Lance, thank you. Have you looked at the total number of medications that the two groups are taking? Because sometimes my HIV-infected patients have some medication fatigue.
No, that's actually a very interesting question. I actually was talking to some folks over at UNC, and they've kind of had very elaborate ways of kind of calculating those medication counts over time. And so, I mean, if you can incorporate some of those techniques, it'd be very useful to our cohorts because it's being done actively. So,
Kara?
Yeah, you know, one thing we did want to look at was, okay, so basically her question was, how does socioeconomic status impact the findings that we have here? The most accepted surrogate way to look at that is at insurance data. I think for publication purposes, getting the distributions of insurance data on all these patients would be essential to kind of like really crystallize that message. So yeah, that's definitely something we'll look into.
Lance, do you want to discuss the control population from where they were selected as a partial answer to Kara's question?
Yeah, so the control population, and I didn't have time to go into that in depth, was actually essentially from the DOC. So it's a very indigent, the Duke Outpatient Clinics. It's a resident-run clinic locally, and it's a very indigent, no insurance-based population. And so that's what we compared against here.
Please?
Yeah, would you be able to look at it? Would you also be able to go back in to look at activity level?
Activity level?
Yeah.
Okay. Oh, yeah, so I think that's a very important question. And if we can, it's going to be dependent on how much in prospective trials with these same cohorts we can capture that level of information, but it's not really well documented in clinic notes and the like, which we're dependent on. That's the restriction of retrospective data. So we would like to have that information, but unfortunately we don't.
Okay, thank you, Lance. Really well done. You must have an amazing mentor. That was just like so good.